Hi, my name is Raquel Vasquez and I'm going to talk about a case about a 44-year-old woman with intractable pain due to metastatic lung cancer. A 44-year-old woman with metastatic stage 4 non-small cell lung carcinoma was seen in the outpatient cancer center of the hospital because of intractable pain. Now we're going to see a video about the lung cancer.
Lung cancer is the leading cause of cancer deaths in Malaysia for both men and women. Your lungs are two spongy organs in your chest. The left lung is divided into two lobes, or sections, and the right lung has three lobes. When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea divides into two bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale. Your lungs are encased by pleura, a thin membrane that protects them and helps them slide back and forth as you breathe in and out. Underneath your lungs is the diaphragm, a smooth, thin muscle that helps your lungs expand and contract as you breathe. Your lungs are connected to small collections of immune system cells called lymph nodes by way of lymphatic vessels. You have groups of these lymph nodes near your lungs, above your collarbones, and behind your breastbone, as well as in other parts of your body. Lung cancers most commonly start in the bronchi, but they can also begin in the trachea, bronchioles, or alveoli. Early lung cancer typically does not cause symptoms. As the cancer grows, you may experience symptoms such as a cough that gets worse or does not go away, shortness of breath, chest pain, and wheezing. Other symptoms of lung cancer include coughing up blood, hoarseness, weight loss without trying, and frequent lung infections such as pneumonia. Other health problems may cause these symptoms. You should see your doctor if you have any symptoms you're concerned about. The staging of lung cancer refers to the extent of the disease. If you have the most common form of lung cancer, or non-small cell lung cancer, it will be staged according to the size of the tumor and whether it has spread to the lymph nodes or other organs of the body. In the occult, or hidden stage, cancer cells are found in coughed-up mucus or in other lung fluids, but no tumor can be seen in the lungs. Stage 0 is not considered invasive because the cancer cells are found in the innermost lining of the air passages but have not grown through it. Stage 1A is considered invasive cancer because the tumor has grown through the inner lining of the airways into the deep lung tissue and has not spread to distant sites. In Stage 1B, the tumor has spread to a main bronchus, or has grown through the lung into the inner layer of the pleura. In Stage 2A, the tumor has spread to nearby lymph nodes on the same side of the chest as the tumor. There are two scenarios that can occur with Stage 2B lung cancer. One, where cancer cells have not spread to nearby lymph nodes, but have invaded the chest wall, diaphragm, pleura, the membranes surrounding the heart, or a main bronchus. In the second scenario for Stage 2B, the cancer has spread to the lymph nodes on the same side of the chest as the tumor, or has grown into a main bronchus, or has grown through the lung into the pleura. In Stage 3A, the cancer cells have spread to the lymph nodes on the same side as the lung tumor. Also, the cancer may have spread to the chest wall, diaphragm, pleura, the membranes around the heart, or a main bronchus, but not the trachea. In Stage 3B, the tumor has spread to lymph nodes above the collarbone or on the other side of the chest. The cancer may have spread to nearby structures or to more than one place in the same lung. In stage 4, cancer has spread to other parts of the body, such as the brain, liver, kidneys, adrenal glands, or bone. If you have small cell lung cancer, it is often staged using a simpler 2-part system, because treatment options don't vary much between the more detailed stages used to describe non-small cell lung cancer. In limited stage,
In this case, we have a patient that had been well until approximately 1 year before this evaluation, when pain in her right shoulder and scapula developed, followed by cough and an episode of hemoptysis. A chest radiograph reportedly showed findings suggestive of pneumonia. Antibiotics agents were administered, but the pain and radiographic abnormalities persisted.
One of the most common questions amongst cancer patients is, will it hurt? The answer varies from person to person. Some may never feel any discomfort, while others may experience aching or sharp pains when breathing. If pain occurs, it can usually be controlled by you, your family, or your doctor. The most important thing is to tell someone, so something can be done about it. Don't just assume you should have to suffer in silence.
There was an occasion where I could hear my heart beating constantly, quite a noise between my 2 ears, and it was continuous, and it was going really quite fast at times.
Because of the location of my tumour, I actually suffered some, should we call it, secondary damage, some collateral damage to other organs. So my esophagus has been damaged, and temporarily my pericardium, the sac that the heart lives in, that got quite badly swollen, didn't it?
that was very painful, wasn't it?
And I was actually seen by a cardiologist.
We turned up, you were seen in about 5 minutes by a cardiologist who gave you very strong painkillers. Because that was
Apparently the cardiologist turned up and gave me some very strong painkillers.
If I had pain, I wasn't to have any pain. I wasn't to allow pain. If I had pain, I had to call somebody. Well, this is when I was in hospital. Because if I had pain, I wouldn't breathe. And as it was my lung, it was terribly important that I breathed, obviously, regularly and kept breathing.
Nine months before this evaluation, computed tomography of the chest revealed an irregular mass in the interior right upper lobe, along with multiple pleural nodules in the right hemithorax and mediastinal and right hilar lymphadenopathy. Examination of a pre-tracheal lymph node biopsy specimen revealed that multiple lymph node fragments had been almost completely replaced by metastatic tumor deposits. Because the patient had never smoked tobacco, genetic testing of tumor tissues for a mutation of the epidermal growth factor receptor gene was performed and revealed a deletion of 15 pp in exon 19. A frame-shift deletion mutation in exon 19 is known to confer sensitivity to epidermal growth factor receptor tyrosine kinase inhibitors.
Over time, we can see the ability of lung cancer to spread. So some of those cells have the ability to get into blood vessels or something that we call lymphatic channels that drain to different glands throughout the body. And that's how lung cancer can spread. The most common sites of spread are brain, to the bone, and liver. Sometimes people will often have cancer outside the lung, so in the lining of the lung, something called the pleura, and lung cancer can even go to the other lung.
The cancer that arises originally from the lung will be considered lung cancer. But then if the cancer arises from some other part of the organ and eventually metastasized or migrated to the lung, they will not be considered to be lung cancer. They will be called lung metastasis from other organs such as colon or breast cancer.
Treatment. Therapy with erlotinib hydrochloride 150 mg daily was begun 7 months before this evaluation, and the patient's pain rapidly lessened. 3 months after, computerized tomography of the chest reportedly revealed a decrease in the size and number of pulmonary nodules. 2 months before this evaluation, pain in the right shoulder worsened. Repeat CT performed 18 days before this evaluation reportedly revealed enlargement of the dominant mass in the right upper lobe and a new pleural effusion. The conclusion: the patient's oncologist recommends discontinuation of erlotinib and administration of standard chemotherapy for lung cancer. 12 days after erlotinib therapy was discontinued, the patient presented erlotinib-resistant lung cancer. She reported incapacitating stabbing pain that she rated as up to 15 on a scale of 0 to 10, and had worsened since erlotinib therapy was discontinued. The pain worsened with reading and lying down, and thus she was required to sleep in a recliner. When she took acetaminophen, hydrocodone, and ibuprofen regularly, the pain lessened to 6 out of 10. Other opioid analgesic agents had no effect or more frequently caused worsening pain.
Some of the new options that are available for lung cancer treatment are stereotactic body radiotherapy. This is a very specific type of radiation therapy that can really pinpoint the tumor and not injure other good lung. Many of our patients with lung cancer have other lung diseases like emphysema or chronic bronchitis, and to give radiation therapy to some areas of the lung that are not appropriate may cause injury that might be irreversible and can compromise their lung function. By being able to pinpoint that radiation, we can localize the effects of radiation to the tumor itself. So these new forms of radiation therapy are very, very valuable. In addition to that, there are new drugs that can attack some of the molecular mutations that occur on some lung cancers. These are very specific drugs, and it's very important to diagnose those mutations that occur in these cancers so that patients can be afforded all the possible therapies that are available. We frequently will use brachytherapy to treat patients who have tumors that have blocked their airways. These treatments are very effective at reducing coughing and blood, opening up the airways so that it improves shortness of breath. It can help treat pneumonias that are trapped behind the tumors in the lung. It can be very, very helpful in reducing cough. So all of these are very, very important in patients who have lung cancer.
The patient was initially treated with erlotinib. Multiple controlled trials have shown that for patients with EGFR mutations, first-line EGFR inhibition yields better responses. longer disease control, and better quality of life than does first-line chemotherapy. EGFR inhibitors typically control the disease for 1 to 2 years before resistance develops. However, even when the radiographic progression is known, a large portion of the overall tumor burden may remain effectively suppressed by the EGFR inhibitor. Stopping the drug can cause the rest of the disease to flare, leading to hospitalization or even death in up to 25% of cases. The patient remained in severe discomfort and was admitted to this hospital 8 days after her initial evaluation at the cancer center. Erlotinib therapy was resumed at a dose of 150 milligrams daily. Conclusion: these patients had a characteristic disease flare after discontinuation of erlotinib, resulting in admission to the hospital for a pain crisis. It is now recommended to consider continuing EGFR inhibitors even after disease progression to avoid such flares as the one seen in this case. Thanks.